Good evening, everyone. I would like to start by thanking the Fulbright Commission on Egypt. I'm really honored to be here. So today my talk is going to be about the prevalence and prevention of cleft lip and cleft palate in the Middle East and the North Africa region. Oops. Okay, my presentation is going to be in two little parts. The first part is a brief background about the condition. So you know that most of us clinicians, we are exposed to different cases that have different etiologies that lead to the same disorder, let's say. So congenital disorders and orofacial clefts is what I do mainly. And according to science, orofacial clefts account for approximately 65% of all craniofacial disorders. Sometimes when in research, they report syndromic versus non-syndromic cleft palate, and I'm going to emphasize today the importance of the difference between these two. And also when we talk about cleft palate and cleft lip, it's important not to forget that we need to define the degree and the extent of the cleft. So I chose this picture to show just a few variations. So a cleft palate could be of different degrees. It could be classified as bilateral or unilateral, and it could be classified whether it's complete, like through the primary and secondary palates, or if it's not complete. Okay, so when I was assigned this topic, I was happy actually, because I thought it's going to be a straightforward task. But as I started reading, I discovered otherwise. So what I did is I did an informal review and appraisal for all the studies that did prevalence research on cleft palate and cleft lip within the MENA region. So there was a wide variation that was described within the Middle East and North Africa countries. I'm going to talk about the problems later, but I'm just going to give a brief generalization of what the main result that they had. So the estimated mean of prevalence of orofacial clefts range between 0.44 to 1.25 per 1,000 births between the Middle East and North Africa. So this high prevalence was more reported in men compared to women, but the most important thing is that they found that the cleft palate was more prominent in women versus to men, whereas the cleft lip was more predominant in men. So after looking at these studies, each study had different numbers that they reported for prevalence, but after investigating their methodology and the sample population, I had some concerns. So the main outcome that I reached is that accurate epidemiological data do not exist for many of our countries. When I say countries, I mean in the MENA region. So after reviewing these studies, I used different search engines and I looked into different databases. I was only able to find 10 studies that would fit the description or would fit the purpose of this review. They were mainly conducted in Jordan, United Arab Emirates, Oman, and Saudi Arabia. So the complete prevalence ascertainment is really difficult to obtain or attend, but there were many limitations with these studies. So today, instead of talking about each study and finding the strengths and limitations for each one, I decided to give an overview of the whole limitation section that includes all the studies. So for these studies, data collection was mainly hospital-based. So they were only referral locations. In Jordan, all the studies were done in the King Hussein Royal Medical Center, which is only one sector of the country. Not to mention that it's only one sector in the capital, Amman. So that was a little bit alarming because there were two studies that investigated the same location, and they got really different prevalence mean rates. And all of the studies were retrospective and were fairly with small sample sizes. And some of the studies have investigated, or actually only one of the studies have investigated live births as well as stillbirths, but all of the other studies were mainly concentrated on the living births. There were other limitations also, that the age of the patients that were included in the study was not mentioned. So sometimes if I say I'm going to do like the prevalence at this time frame, they didn't report how many people fit that age limit. And they also included the syndromic and non-syndromic orofacial clefts. Let me just explain why this is important. Sometimes orofacial clefts can be due to mechanical reasons, which means they're not due to a genetic defect, but merely for example, for crowding in the uterus. So it was only a consequence for other factors, not the actual disorder itself. And they excluded some of the types of the clefts, like submucous cleft, which is only like a cleft in the muscle where the mucosa is still intact, and that also created a problem where I thought that these numbers that they reported were not very reliable. They also, like for the study that was conducted in the United Arab Emirates, it was so heterogeneous that the sample didn't represent the inhabitants of the country, but represented everybody, even the visitors and some of the immigrants. So I came to the conclusion that we cannot really generalize any of the results that I found in these studies, and they were not also in congruence with what was reported by the WHO organization in that regard. So when it comes to the prevention of cleft palates or orofacial clefts, then there's the ultimate goal that should be considered is the prevention. So how can we prevent cleft palates or cleft lips from happening? So we need to do more extensive research on the exact etiology of the disorder. Of course, there are different resources of what the etiology is, but more investigation is needed. And we need to come up with a system that would successfully implement the prenatal vitamins and folic acid prevention strategies, improvement in surgical procedures. As like I'm exposed to the field, I see that most of these children don't seek medical or surgical attention until it's really late, like when they're beyond 7 years of age, and that creates a very big problem for the patient. So there are lots of factors to consider to provide hope for these patients. Lots of it comes with early intervention, and that they know that there is help that they can seek. I don't want to end my discussion by just pointing out the limitations of other people's work. It was easy for me because as a researcher, I can see where the weakness points were. But as a person who works in the field, I can tell you from first-hand experience that it is very difficult to get to this population. Like, I've worked with 3 different groups in Jordan, and I work with one major group in Morocco, and we're trying to reach these kids and to early identify their problems, but it's a very difficult job. So I don't do any epidemiology-related research. My research is mainly acoustic perceptual based, but I need to find these people. I need to find them and get samples. My samples are merely just a voice recording, and a vowel would be enough for each patient to give me. But even with that, I find myself limited with the resources, limited even with the politics. Like, I can't reach people in remote areas. I've tried to expand my research on other countries because I'm trying to find a universal measure to scale hypernasality, which is a byproduct of cleft palate. So I went to China, I went to the DRC, and I included Arab countries as well, like Egypt, Morocco, and Jordan. But the main complication and the obstacles that I found was that I cannot reach out and find these people. So I think that's one of the major problems that also these researchers faced, and that's probably the main point or why they face these problems. Thank you very much.